Hyperkalemia corresponds to an abnormal elevation of potassium levels in the blood, defined by a plasma concentration greater than 5 millimoles per liter. The normal range is between 3.5 and 5 millimoles per liter. This abnormality results from an imbalance between potassium intake and excretion in the body. Among electrolyte disorders, hyperkalemia is the most serious because it can lead to severe cardiac disturbances that may be life-threatening. It is a diagnostic and therapeutic emergency requiring rapid and effective management. In most cases, hyperkalemia is asymptomatic or presents with rare and non-specific signs. When present, these symptoms can affect several systems. The cardiac manifestations include chest pain, bradycardia, and the ECG shows some abnormalities that may precede severe arrhythmias. The neuromuscular manifestations, like some paresthesias or tingling, muscle weakness, and alveolar hypoventilation in severe cases. Digestive manifestations like nausea, vomiting, and ileus, which is an intestinal transit paralysis. Hyperkalemia is confirmed by a plasma potassium level greater than 5 millimoles per liter. However, before making a definitive diagnosis, pseudohyperkalemia must be excluded, which can be caused by hemolysis induced by a blood draw with a tourniquet that is too tight. It is therefore recommended to repeat the sample without a tourniquet, delayed centrifugation of the blood tube, which can distort results, or severe leukocytosis higher than 100,000 per cubic millimeter, or thrombocytosis greater than 1 million per cubic millimeter, which can artificially increase measured potassium levels. Once hyperkalemia is confirmed, rapid management is necessary due to the high risk of cardiac complications. The assessment of hyperkalemia severity is based on electrocardiogram analysis, which must be performed urgently without waiting for blood test results. The electrical signs observed in hyperkalemia are diffuse, not systematic, and evolve through several stages. Stage 1, marked by an appearance of a tall, peaked, and symmetrical T wave associated with a shortening of the QT interval. Stage 2, marked by the flattening of the P wave and the prolongation of the PR interval, indicating slowed atrioventricular conduction. Stage 3, there is a disappearance of the P wave, widening of the QRS complex, and ST segment flattening, reflecting major disturbances in cardiac conduction. And finally, stage 4, marked by an appearance of broad biphasic ventricular complexes, followed by ventricular fibrillation, VF, that can progress to cardiac arrest. Important note, there is not always a direct correlation between the plasma potassium level and ECG abnormalities. Even moderate hyperkalemia can lead to severe arrhythmias. Certain factors can increase the risk of severe complications, particularly cardiac arrest. When the potassium level is above 6.5 millimoles per liter, cardiac arrest may occur at any time, necessitating urgent, life-saving intervention. A rapid increase in potassium level, which does not give the body time to adapt, increasing the risk of arrhythmias, metabolic acidosis, and hypocalcemia, which exacerbate potassium's toxic effects on the heart. Underlying heart disease, especially ischemic, which weakens the cardiac muscle and increases sensitivity to rhythm disturbances. Rapid identification of these factors allows anticipation of complications and optimization of hyperkalemia management to prevent a fatal outcome. The etiological diagnosis must be rapid as it should not delay treatment initiation. Among the various causes, medications are the most frequently involved. Diagnostic orientation is based on measuring urinary potassium excretion, kaliuresis. If kaliuresis is less than 10 millimoles per liter, meaning the excretion is inadequate, there is a renal potassium excretion defect. This can be caused by renal insufficiency, whether acute or chronic. Mineralocorticoid deficiency, found in adrenal insufficiency and hyporeninemic hypoaldosteronism syndrome. Medication effects, particularly with ACE inhibitors, angiotensin II receptor antagonists, and nonsteroidal anti-inflammatory drugs. Aldosterone resistance, which may be secondary to potassium-sparing diuretics like spironolactone, or congenital abnormalities. If kaliuresis is greater than 10 millimoles per liter, then the excretion is adequate. There is either a redistribution of potassium to the extracellular space or excess potassium intake, which can be caused by cellular lysis, observed in traumatic or non-traumatic rhabdomyolysis, for example, tuck-out syndrome, extensive burns, hemolysis, tumor lysis, hypothermia, intense physical exercise, and sepsis. hyperchloremic metabolic acidosis, which promotes the release of intracellular potassium, insulin-deficient diabetes, and hyperglycemia, which impair potassium regulation. Medications promoting hyperkalemia, such as digitalis, beta blockers, and succinylcholine. Hyperkalemic familial periodic paralysis, a rare condition related to dysfunction of muscle ion channels. Hyperkalemia can also result from excessive intake, although this cause is exceptional in the absence of renal insufficiency. It may occur during rapid intravenous potassium infusion or excessive dietary intake, combined with impaired kidney function.